All
Yep.
right. Thank you all so much for sticking around to this final talk of the afternoon. I am absolutely delighted to share what are brand new, hot off the press data with you all. My talk's going to be a little bit different. It's a little bit of a different angle to what we've seen so far because instead of analyzing an existing PTSD cohort, we are in the middle of a trauma and we are trying to track that trauma and people's responses and feelings and behaviors in real time. So this is really kind of day 0 or day 28 of creating some of the cohorts that we've just seen being analyzed. So the motivation for this study, back in kind of mid-March, we realized that New York City was going to be the epicenter of the coronavirus outbreak, and that Mount Sinai, we've been calling ourselves the epicenter of the epicenter. We're the largest healthcare system in New York City. And it became clear to us working at Mount Sinai that understanding this outbreak is the most important thing that we can be doing with our time right now to try and help our hospital. So a lot of the data that existed back in kind of mid-March and even through April has come from European countries, from Asia. It is a very different situation that we face here in New York. Unlike all these other countries, a large majority of our population don't have access to healthcare, or a large proportion, not a large majority. We saw a study coming out of the Evidation Group in late March that showed that 20% of people who don't have healthcare insurance will not seek healthcare for their coronavirus symptoms under any circumstances. So that's a huge number of people in New York City who will never enter hospitals and will never be captured by those hospital-based studies. And all the data that we're getting from the government here, from most international studies, are hospital only. So it was really important to us to come up with a study that is about all New Yorkers and is for all New Yorkers. And as we started developing this, we also saw a lot of talk in the media about racial and ethnic disparities as well in outcome and in tracking. So it was really important to us that our study didn't have those issues. So we came up with the idea for a text-based study. New Yorkers are fairly used to getting information about their government and their healthcare through texting. So we have a Notify NYC hotline that tells you about, blizzards and parking restrictions and all those kind of minutiae of daily life. On about the 10th of March, the New York government launched a coronavirus notification service. So you could text COVID to one of their numbers and get kind of daily updates about social distancing guidelines. And that works very well. You don't need an iPad, you don't need a computer, you just need a phone. So we mimicked that for our study. And we came up with this system whereby any New Yorker can text COVID to 64722, and they're then enrolled in our study. They go through a consent bot, so they do the informed consent procedure as usual. They complete a brief survey about their symptoms, their demographics, pre-existing conditions, and they then get a daily survey to track their symptoms. So basically this lets us track not only the contagion throughout the city, but also the trauma in real time, right? So this provides the data that we will use in the future to understand mental health and impacts. So let's go into that in a little bit more detail. So the key goals of our app, as I've said, are daily citywide surveillance of COVID-19 symptoms. Crucially, it's outside hospitals. We'll be able to capture mild and moderate cases. Our questions are tailored to the New York City population. So there's things about subway and bus ridership that perhaps wouldn't be appropriate in the wider USA. We have citywide surveillance of COVID-19 risk factors, like pre-existing conditions. You can tell from my accent that many New Yorkers are not born in New York. It makes our city a perfect place to study various protective and risk factors, right? We have a very diverse population. We have a very high proportion of immigrants. We can study things like immunization programs across the globe and what impact they have on infection rates in New York, for example. And perhaps most importantly, this creates a COVID research-ready cohort. So as scientists, I think we all understand that in order to beat the disease, we have to understand it, we have to be able to research it. So this really gives us a large group of people who are very keen to be part of our research. People really want to help. New Yorkers really want to be able to do anything they can to help. So being able to contact those people and deploying various surveys, I think is going to be a really powerful tool in the coronavirus epidemic. So we've had to move very, very quickly in all of this. So on the 19th of March, we officially formed our Slack channel, which now that we all work from home is like the birth of any project, is the creation of the Slack channel. Oh no, there we go. So the initial task force was myself, Paul O'Reilly, and Alex Charney, our PIs in the Pamela Sklar Division of Psychiatric Genetics here at Sinai. Dara Meyer is our amazing project manager. She's the person who makes sure we actually do stuff, which is vital. And Clive Hogarth is a postdoctoral fellow, and he is our predictive modeling guru. So you'll see some predictive modeling that he's done later. On the 1st of April, we launched our Stop COVID NYC app. So it was just less than 2 weeks from formation to launch. On that day, we put out this ad that I showed you earlier, and we also put out a press release. We were pretty lucky to get fairly large amount of coverage in the news. So both local, national and international news covered our app, and that really helped us get a lot of people enrolled. So by the end of the second day, we'd had more than 10,000 responses. By the 5th of April, we'd had more than 25,000 responses. And by the 15th of April, 2 weeks in, we hit 100,000 total responses. So that's not 100,000 unique people. That's people who fill in the baseline survey and then complete the survey every single day. And a surprisingly large number of people have completed the survey every single day throughout April. I'm sure a large portion of those people are related to me or work with me. But given that it's around 1,000 people who are completing this kind of almost every single day. So we're getting a really nice longitudinal measure here. So the 15th of April, we created Data Freeze 1.0. That's all the data that I'll be talking about in this talk. As of yesterday morning, we had 140,000 total responses. We're launching Survey 2.0 today, which I'll talk through. So that includes things like mental health. And we're also performing Data Freeze 2.0 today to capture kind of 4 weeks worth of coronavirus data throughout New York City. So this is what our daily survey looks like. It's designed to be incredibly quick and easy to complete. It's a checklist of symptoms. You just select the ones that apply. We ask you how bad your symptoms are. And we ask whether you've left the house. And if you say yes, we then say, did you get the bus? How many people did you interact with? Our one-time only survey, so the very first one they see, looks very similar. It's checkbox based. I'm not going to go through all of it because it's a little bit long, but it's really easy to use and designed to be kind of clickable. So Data Freeze 1.0, like I said, captures the first 2 weeks of app usage and 100,000 or so data points. We asked some key questions. I don't have time to go into all of these, but Paul and Clive, I believe, are ready to answer your questions in the chat bot, and we can talk about all these things in more detail in the breakout rooms afterwards. So let's just go through those. So who is using our app? In line with most surveys, the majority of our users are female. Encouragingly, the age breakdowns roughly match the age breakdowns in New York. So that was really nice to know that the elderly population in New York is using our survey. On average, it took people about 4 minutes to complete our baseline questionnaire. So we're pleased to know that that's not too much of a burden. And about 20,000 users have completed every single question in the baseline questionnaire, and a much larger number have done 1 or 2 of the questions. We have an underestimate of non-white populations here. So we have more white Europeans than we'd expect, should be about 42%, and we get 52%. And we have an underestimate in particular of the Hispanic community in New York City. So we're launching the survey in Spanish and written Chinese, since those are the second and third most commonly spoken languages in New York City. I'm not going to go into those. The basic symptom profile, so this is on day 1, roughly half of our users have no symptoms. The next most common symptoms are headaches and runny noses. And in general, people don't rate their symptoms to be bad, right? The average symptom score, symptom rating is 1. However, among those people, we had 500 or so who had received a test and 250 who had a positive test result. Looking only at the people with a positive test result, we can see which of these symptoms are enriched among people who test positive. And as we might expect, loss of smell and taste, shortness of breath, fever, high temperature are all enriched among people who test positive, and having no symptoms are significantly decreased among people who test positive, and positive testers rate their symptoms as significantly worse, exactly as we expect. So this is a kind of the most basic model we can do. Clive Hogarth, as I mentioned, is our predictive modeling guru, and he'll answer more questions on this. But he's done a much more sophisticated algorithm that pulls in your likelihood of being tested because that's not neutral, right? There's a whole raft of factors that influence that, and is able to predict who might actually receive a positive test if they were to be tested. So for more questions about that, we can talk about that later. We're able to track symptom scores through the city. So here we're just using a basic symptom score that gives you 1 point or 2 points or 3 points for various different coronavirus symptoms. You can see there are certain zip codes in New York where there's higher average symptom scores. And those zip codes correlate very closely to the zip codes that have higher percent of positive tests. And the picture on the right in green is based on New York City government figures of coronavirus testing results, not from our app. So we're seeing that we are able to capture the same spread of the disease through the city as we're able to do with testing. But of course, we haven't actually tested anyone in our app, right? So it's symptom only. So we're getting a good picture of disease spread based only on symptoms. We also wanted to know whether New Yorkers are complying with social distancing. In general, they are. Roughly 50% are leaving the house every day. Only 2% are using the bus or subway every day. That's a 95% decrease based on what we would expect. And in general, people are having less than one face-to-face interaction per day. So they're interacting with fewer than 1 people a day. Those of you who are PTSD researchers know that this is a huge risk factor downstream, right? Not leaving your house, not interacting with anyone is going to have a huge amount of knock-on mental health effects. In general, people are becoming less likely to leave the house during these 2 weeks. So we have a downward trend in proportion leaving the house. There's no relationship with any kind of weather, temperature, wind, rain, hours of sun, despite what you see in the popular media. It was a suspicion that the decrease in leaving the house over time may be because those people are more compliant in general. So if you're still filling in our study on the 15th, perhaps you're just a more compliant person, right? You love filling in surveys, you love following laws. If we correct for that effect, so if we correct for people who love to fill in surveys and do it every day, the downward trend still remains. So it seems like New Yorkers are less likely to leave the house over time, which is great news. This slight increase on the 11th and 12th, it's a weekend, it's Easter, it's Passover. We expect that all those factors are kind of coming together to increase that number. Sick New Yorkers are staying home, which is great news. So here we're looking at your symptoms on day 1, predicting your behavior on day 2. So if you're sick today, do you stay home tomorrow? And in general, if you have any of the coronavirus related symptoms, yes, you'll stay home tomorrow. If your integer score, so if your kind of sum of coronavirus symptoms is high, you are less likely to leave the house tomorrow. And if you have these non-coronavirus related symptoms, sneezing, itchy eyes, runny nose, there's a slight effect, but these don't survive correction for multiple testing. So these don't seem to affect the chance of leaving the house. However, there's a subset of New Yorkers who aren't able to modify their behavior based on their symptoms. So there is no effect on bus or subway usage based on symptoms today, which perhaps implies to us that there are some New Yorkers who are essential workers and are not able to stay home. At the moment, we're really only seeing subway usage from people who are essential workers. So perhaps they aren't able to take time off or have sick leave. Okay, so that's kind of the end of our incredibly quick run through our Data Freeze 1.0. Survey 2.0, which launches tonight, will also capture mental health. So there are going to be huge impacts of COVID-19 on mental health, as we all know. Social distancing is perhaps the most obvious one. In New York, we also face really substantial financial worries. You will have seen that the government stimulus package is insufficient. It's going to be especially bad in New York. The amount of money allocated does not cover 1 month rent in the city, and a very large number of New Yorkers will be ineligible because it doesn't apply to immigrants and all kinds of different reasons. So that's going to be a huge impact on our community. We also see lack of access to support networks, treatment, and therapy. So even though many therapists have moved to telehealth, I think at Sinai we're seeing fewer people coming into the psych ER even. So somehow these serious psychiatric events aren't receiving the same kind of care that they would have done before the pandemic. And we're also starting to see some kind of breakdown in food supply chains. Some of the supermarkets in kind of downtown Brooklyn have stopped selling food. There's lack of access to protective equipment. All of these things obviously going to be huge mental health impacts. And we also expect a worsening of a range of inequalities, especially racial and ethnic inequalities and income disparities throughout the city. So even though our current study doesn't explicitly request mental health details, we do ask, are there any other symptoms associated with coronavirus that you want us to know about? And we see that people have reported all of these symptoms already, specifically associated with coronavirus. So based on this, we launched Survey 2.0, which collects a range of mental health related details. The PHQ-9 basically adapted here to capture depression and anxiety. We'll ask specifically about coronavirus coping strategies. We ask what their main concerns are for coronavirus. We have a raft of PTSD related questions. So this is kind of coronavirus related PTSD. And we also have a number of screener questions. This isn't an exhaustive list, just an example of things like OCD, psychosis, suicidality. And this really allows us to identify people who we might want to study in more detail or we might want to reach out to. And of course, with all these surveys at the end, all of our participants are presented with a list of resources. So people aren't on their own. They have a way to contact someone for suicide prevention, for domestic violence assistance, and all those kind of things. So this is my final slide. I know I'm at time. I'm sorry, Topher, for talking a lot. The most important thing to us is that nothing great is ever achieved alone. Our goal is to share our findings, share our data, and share our resources. We really don't want to be coronavirus researchers, right? This is the #1 study that we hope to be scooped on because we hope someone else will solve this or the problem will go away. But our goal really is to work collaboratively and to make these data available as quickly and as easily as possible to our colleagues. So we would be delighted to hear from anyone who wants to collaborate or wants to work together on this. We already have a lot of collaborations going on. So we're looking at people who leave the Mount Sinai healthcare system and tracking their mental health and their physical health in the weeks after they're hospitalized. We're looking at healthcare workers. We're looking at collecting biospecimens in parallel, collecting genetics as part of the Host Genetics Consortium. We're working with the PsychEmerge folks and so on. These are all the PIs in the NYCIT task force. So everyone kind of working on coronavirus research at Mount Sinai. There's so many postdocs and PhD students. We're so grateful for all of their help. And in particular, my team, I should mention Amanda Dobbin and Jia Zhu have pulled together a lot of these data into these tables for me incredibly rapidly. It's been about 5 days since we got the data dump from Data Freeze 1.0. And Hillary is working with coronavirus patients at Mount Sinai right now and has been really helpful in giving us insights into kind of what the community is going through and what might be useful questions. That's it.
Well, very good. Thank you, Laura. So I think we have time for a few questions, and just as a reminder, just the links to the individual rooms have just been posted in the chat here. I see this. Can you remind me, I may have missed this as well, what the current size in terms of participants of the research cohort is and the frequency of longitudinal data collection?
Sure, yeah, so we have about 140,000 responses. That represents about 40,000 unique people. It's a little bit difficult to tally exactly how many unique people we have. So everyone completes the daily surveys. Not everyone completes the baseline surveys. A lot of people forward the baseline surveys to their friends. So we'll have baseline surveys linked to the same phone number with 2 different names. We've spent a lot of time cleaning that, and our best estimate is about 40,000 unique users for 143,000 entries. On average, people are filling in 6 daily surveys, not always on consecutive days. So sometimes they'll skip a day, come back. Yeah.
Okay. And then just maybe from a technical perspective, for if one were to add the biospecimen collection, saliva and other fluids to this, I mean, how would that work technically? Would you rely on bank samples, bring people back to take a swab for the saliva? What is the vision there?
All. So this is kind of part of the effort that the wider NYCIT is working on. So we have one study that looks at patients who are currently hospitalized, which Alex Charney is leading, where we try and collect longitudinal samples from patients in our hospitals. We have linkage to the Sinai EHR, so all of their historical data and any previous biospecimens. So for example, we have a biobank that we can link to. We have a plan to test our predictive modeling by contacting people from our survey and asking them to get tested. So we'll identify people who we think are highly likely to be positive but haven't been tested and test them. We also hope to be able to, send out things like antibody tests and a whole range of different stuff. So yeah, every different biospecimen option that there is, we have someone kind of working on that angle and tying all the data together.
Well, very good. Are there any additional questions for Laura before we move into the individual rooms or the individual discussion?
Vangelis Vassos, he says, as a great effort, Laura, are you checking the location of the respondent through the phone location apps?
So we are checking them currently through their zip code. For the individuals who are also Mount Sinai patients, we have their full address, so we can do geospatial kind of classification of those details. We're not using the actual physical location of the phone. And we did think about this, and the main reason that we didn't do that is that for people who are still working, right, so for essential workers, it is going to do a disproportionately bad job of tracking their location. So the people who are at high risk are going to come up with kind of, they're most likely to do this in a Starbucks, on the subway, while they're kind of moving about their day. So for people who are sat at home and safe, we're going to get a very good impression. For people who are moving about and unsafe, we're going to get a bad impression. So for that reason, we decided to stick with their home zip code or their EHR reported zip code.